immune system is supposed to do a job and then quiet down. And if the immune system starts doing that job, it gets activated and stays activated, that's when the trouble happens. If the off switch doesn't work, then you have problems.
We can't fix it if they don't know what it is. Of course, it was just this monster thing that happens.
It is a disease of the white blood cells, so it's a blood cell disease. And autoimmune is a little bit inaccurate. Most common autoimmune diseases are more specifically targeting the joints or the skin or the eyes or the lungs, not everything. That's why I think it's better to think of it as dysregulated immune system.
Nobody sort of in their kindergarten, what I want to do when I grow up, I think says, I want to become a histiocytosis biology researcher. So how does that happen? My very first patient when I was on call was a little boy who came to the ICU who had his 3rd birthday 2 days before, had been perfectly healthy riding his bike, and suddenly he's on maximum life support on an oscillator, and he's dying, and we couldn't figure out why. And, he was somebody who we did recognize that he did have HLH, and we started therapy, but it was unfortunately unsuccessful. But I had never heard of HLH before. I had been at a major medical center, and we had never diagnosed a single case of HLH in the 3 years that I did my residency training. We'd made a diagnosis, and the dad asked me a very simple question. He said, well, what is HLH? Is this a cancer or an immune problem? I can't figure out what it is. And so when a first-year fellow grabs his pager and leaves the room and says, oh, I have to answer this page, that means we have to go to the computer and look things up. I didn't know. So I looked it up and I realized that nobody knows. I said, well, how can it be that there's a disease like this where we have no idea what it is? I think a very dramatic example to me how it's so important for us to understand the diagnosis. And I think this was a case that was managed optimally. And even in optimal cases, there's a 50%, more or less 50% survival rate.
Ever heard the name hemophagocytic lymphohistiocytosis? And I went, no.
Hemophagocytic lymphohistiocytosis. So hemophagocytosis is when our cells follow rules of personal space, right? So they won't eat their own cells. They won't. If there's a cell here, they won't mess with the cell that's sitting next to it. But when the immune system gets so activated, the macrophages will just eat anything they see. So when you look under the microscope, you'll see white cells, you'll see red cells. So seeing a red cell inside of a macrophage is erythrophagocytosis or hemophagocytosis. So it's just a pathological description. And it's common to HLH, but it's not necessary, and you see it in other conditions too. That's why it's a little bit of an unfortunate name. Ken and I really think it should just be called too much inflammation, TMI.
Too much TMI.
We're working on that with the Histocyte Society. So.
Good luck.
Yeah.
HLH, as Carl said, we understand the biology, but making the diagnosis is extremely frustrating. And so there are so many ways it can present. Fever of unknown origin, a skin rash like a virus rash. It can present like liver failure, bone marrow failure, seizures. So all these things kind of come at you from different directions, and it's like the old story of the blind man and the elephant. You have a hold of the tail or the trunk, and so if you don't take off your blindfold and look at the whole beast, you miss the diagnosis, and that's why we really need to get better diagnostic criteria. Dr. Filipovich and I have been taking care of HLH patients for over 30 years. So we really do have a lot of experience about what is it like when these patients are just coming in, what happens to them day by day, and it's very, very tricky, and unless you have that corporate experience, it doesn't make sense, because you put a name on it, MAS or HLH or GRA or something like that. And that's the problem with medicine, is when you focus like a microscope on something that you should be using a very wide-angle lens on, you kind of miss the details.
At most centers, people say we seem to be seeing a lot more HLH. I think a lot of that is that it's recognized. I think years ago there were many patients that had HLH, died from HLH, and no one had any idea, even after the fact, that they had HLH. So I think it's increasingly recognized, and so more patients are being picked up, being treated, and being referred, for sure.
I'm Lisa Filipovich, and I've been here at Cincinnati Children's for 16 years. And during that time, one of my great privileges was to begin to grow the HLH program here. Something that caught my interest when I was very early in my medical career. Very little known at the time. It was really a discovery field, which it continues to be today, and also very challenging clinically in terms of many of these children needing to have a complete reboot of their immune system for survival and for good health. Because the resources were available, we began developing tests in our diagnostic immunology lab, which is not a research lab, it's actually a clinical lab that services all of North America. And we were able to develop most of the key diagnostic tests currently available for HLH. So being able to make the diagnosis is the beginning of curing the disease. I see patients with a variety of histiocytic disorders, but I have a much broader interest, which is really all genetic immune deficiencies, and this happens to be a subset that is developing very quickly and that we've developed expertise in. We probably see around 30 cases of HLH, and then twice as many of the other histiocytic disorders. That's actually more common than the number of leukemia patients we see. And the leukemia patients might be 125 a year. It's rare on a single hospital basis or a single doctor basis, but we see them not because they all live in Cincinnati, it's because they come here for treatment. So there are tests that identify that the immune system is activated in an abnormal way, which occurs in HLH. There are tests that identify what the genetic basis is, so that we know with certainty what caused the disease, and we can also test other family members. For example, if we're going to do a transplant and there's a match in the family, we want to make sure that that individual is not affected with the disease. So it gives us a lot of power in planning curative therapy effectively. If the disease gets better, but then it recurs, that's almost always an indication that it is that there's a genetic basis and that transplantation is appropriate.
Does that happen a lot, the
Yes.
reoccurrence?
So even with the standard successful initial therapy, about 35% of patients will have a flare of their disease within the first 6 to 8 weeks after diagnosis, or a reactivation within the first 6 months after diagnosis. There are many gene defects that all of us, it's estimated, carry 4 to 6 genetic defects that could cause a very serious disease. And there are there are thousands of gene defects that are associated with various diseases. Now in the future, we'll probably have a little chip that has all the bad genes on it, and you probably get it from the husband and the wife, and I think it may be something in the future so that people are aware.
My name is Hannah. I'm going into 3rd grade.
What do you want to be when you grow up? I want to know that.
A photographer or a doctor photographer or a doctor.
6 hours of a nosebleed. In any normal circumstance, she looked as normal as can be. If that nosebleed had not happened, she wouldn't be here. She had a platelet level of 16, which in a normal scenario, normal levels are 150 to 400. So basically what that meant is her blood couldn't clot. We were in the hospital for about 7 to 10 days, and they did a bone marrow biopsy, and that's how they found HLH. Now her liver is shutting down, her spleen is enlarged, she's got fevers on and off, the bleeding is still happening. At that point I said I'm going to contact Cincinnati directly. I sent Dr. Filipovich an email on a Saturday, like at 10 in the morning. 45 minutes later I had an answer. So that pretty much summed up, and she said, I think you're due for a second opinion. We were there for 6 months.
Dad called. Thank you, honey. Bridget wants to say goodnight, so right after your interview.
Okay.
It's called HLH.
And what does that stand for?
I don't.
Come on, try.
I forgot. It's a big word. I forgot.
But then you had a bone marrow transplant.
Yeah.
Do you remember that?
Yeah.
Yeah? Was that scary, huh?
No.
It wasn't? Because you were really brave. And you had your family all around you? Yeah.
We had to look into the registry here in the U.S. through the National Marrow Donor Program, and we waited, and there was no match here either. So they finally had to go to the international registry, and that's how we found our donor. Hannah's genetic link to HLH, we don't know what that is yet. It's so, that's maybe 10 years from now, maybe 5 years from now, if we're lucky, we'll know. Until then, Hannah is definitely HLH free. I worry about my other children, if that could ever happen to them.
I want to tell people that I want them to be a bone marrow donor.
So you can prove somebody has primary HLH. If they have a known gene mutation, you can say that they have an inherited form of HLH. You can call that familial or primary or whatever. But you can't prove that somebody doesn't have primary HLH because half the kids who have HLH, who inherit it in a familial pattern, we don't know what the gene defect is. So how do you prove somebody doesn't have primary? So that's why I think it gets tricky, because people say, well, we assume it's secondary because they have an infection or something, but almost everybody with familial HLH has an infection that's a trigger as well.
Most of the FHL genes are inherited as autosomal recessive conditions, which means that there's a 25% recurrence risk for siblings, for full sibs in that family, and that would not depend on the child's sex. For XLP1 and XLP2, similarly, there's a 25% recurrence risk overall, but that recurrence risk is limited to males. So in those families, half of all males would be at risk for developing XLP1 or XLP2 if we're talking about one of the X-linked genes. Even women who test negative for these X-linked conditions can indeed be carriers. And that's part of genetic counseling. When you meet with a genetic counselor will go over that with you. And then what we can do from a diagnostic standpoint is to test males, basically.
If somebody's pursuing in vitro,
then you would test the embryos before implantation.
Yeah.
With the recessive conditions, the story's a little bit different because remember, for those it takes 2 mutations. So it's pretty rare that you get 2 mutations occurring spontaneously in one individual. So those, for the most part, we almost always can trace those mutations back as far as we can look, essentially.
So you're saying like on the perforin one, like for
For
example,
the perforin, STIX, 11,
Okay.
STIX BP2, yeah, for all
So
those
that's
recessive
like
conditions, we usually see
far
that
apart.
generation after generation after generation. Now that doesn't mean the disease presents generation after generation.
Sure.
It just means that the mutation is present,
Okay.
and that when that person then meets up with someone in the general population who has a mutation in that same gene, then we see HLH. If I'm a carrier of HLH, there's about a 1 in 150 chance that my partner would also be a carrier of HLH. And that's the only time that I would be at risk. So for your kids, the recurrence risk is fairly small. For yourselves, the recurrence risk can be quite high if you're one of those families who have a genetic cause for HLH. But for sibs, brothers and sisters, half siblings, the recurrence risk drops off dramatically. And for those secondary relatives, it's about 1%. So much less than 25% recurrence risk that the nuclear family experiences. Just how common variants are in the 5 genes that we typically look for. You can imagine if you're looking for 100 genes, which is kind of our approach, or looking at thousands of genes, which is the whole genome approach. It's just so difficult to try to sort that stuff out.
They say HLH is 1 in 1.2 million children.
I think the number that we use is about 1 in 50,000. So it's more common than what physicians typically recognize, I think. And so half of those, half of those are going to have a genetic form, half of them aren't. And of those kids with genetic forms, we can identify mutations in about 70%. So you could do that calculation and kind of come up with a number.
You're saying it's about 1 in 50,000?
That's typically the number that we use. Is that correct, Lisa? Yeah, about 1 in 50,000.
The only study that was a population-based study was done in Scandinavia, predominantly Sweden, where they record something about everyone who's born, and they can pretty much figure out which patients had HLH and how many patients were born, in the birth year of that patient or among number of individuals in the population. So that's where some of those estimates come from. And I think your point is very germane, because if the diagnosis wasn't made, or the correct diagnosis wasn't made, they wouldn't be counted.
Right.
And we know, that there are babies who die in infancy of unknown cause, and some of them may have the disease.
So nobody truly knows the number.
Not in my opinion.
Yeah.
My name is Oliver Gillier. I'm the father of Miabel Gillier. She showed signs of dehydration and fever. We went to the hospital. They diagnosed her with Pseudomonas in the blood, which is a severe bacteria. It's called a hospital bacteria. She had E. coli in the urine, and she had adenovirus in the stomach. They could not explain how a baby had so many infections. They treated with antibiotics for 14 days. She recovered very well, which was pretty incredible, because the doctor said 24 to 48 hours later she would have died if we were 25 hours later. So they treated, she did well, we got discharged, and within 24 hours we were back with the same symptoms. Her blood work is all over the place, her liver is inflated, but there's no reason why. They only got to the diagnosis after she lost control over her limbs and her eyesight. She did not have control over her eyes anymore. So they realized that if it was an illness or a virus, it had to reach the spine and the central nervous system, which it did. And they said it's cancer, blood disease, or HLH. And when we asked, what should we hope for, they said, well, hope for cancer. So it was HLH. We had to go on the donor search. We definitely did some marketing to add to the registry, but none of them were matches. So we had to go with cord blood instead of an adult donor, which is good in certain aspects, but worse in others. We had her cord blood frozen, but because it's FLH, it's in the gene, so we can't use it. So we're giving it to research.
Good for you. So your daughter's here in the hospital now?
Yes. In about 3 days, she'll get discharged. Still means we have to live in isolation at the house and be very careful, but at least we get to go home. Today we're doing a dressing change. Actually, Mama is doing a dressing change, which has to be done weekly to make sure that there's no infection. Good job, it's okay.
Over there without hurting you. I'm sorry. I'm sorry.
It hurts a little bit.
Hold on. Look at that.
Mama cannot touch anything that is sterile with her regular hands. And then when it's all on the pad, she can actually put new gloves on
We're using ChloroPrep to clean the whole area. Last couple of weeks of doing it.
And then she will get a
Port.
port,
Sorry.
which is actually underneath the skin, which only needs to be cleaned once a month. And the skin actually makes it waterproof, which this is not actually. This we got to be very careful not to get water on. Right underneath the two existing ones, which is where the two first lines were in, and then unfortunately the lines
I'm saying hi to Papa. You're so funny.
the lines actually stopped working, so she needed a new surgical procedure to remove the two old ones and get two new ones placed.
Yeah, the butterflies are flying all around. Our new dressing, and apply the new bio patches. Cover up the line sites, and they have medication in them that protects from infections. Good girl. Yay. There we go. That's the most critical part. Tightly sealed and protected. That takes care of the dressing change. Yay!
Yay! Heparin is to flush the line to make sure no blood clogs in the line.
You ready, princess? I'm gonna do your pink line first, okay? All right. You can put your new cap on. Take the old one off first.
This
The
is
line
one
is clamped, but it's still
very dangerous.
access into her system. So we have to put some sterile saline around here. Attach the new cap.
And flush.
Unclamp. And flush, flush, flush. Close it back up. Thank you, Mia Bell.
Mia Bell is so good that she knows that the syringe needs to go into the blue line. She's really good at this.
If we left her to her own devices, I think she would actually flush her own lines at this point.
I think she
She's
would.
become a pro.
There doesn't seem to be permanent damage in the central nervous system. And the excellent job here at Cincinnati Children's allowed her to recover very quickly. That's the key with this illness. It's so aggressive and so fast. You know, the fact that the doctors got involved very quickly and realized it saved her life.
Between you and your wife, you both had a mutation.
We both have it. I mean, what's the chances? A Belgian from Belgium who just came to the U.S. 10 years ago and a Puerto Rican from New York meet and they both have it. Bad luck. But, you know, it's life.
Yeah, good deal. The hospital at New York Presbyterian, which is what, the fourth in the country, which is has 1 to 2 cases a year.
We had one in Buffalo. They said, well, the patient was able to walk out on her own in 4 months. I'm prepared to go the distance. I can live with this. We didn't have 4 months.
Yeah, it goes fast.
Did it?
We noticed also with our daughter, from the initial viruses that started infecting her, approach with the doctor saying, we don't know what it is, you've got to go somewhere else to save it. But most doctors won't even do that. Most doctors will be like, okay, let's see what else we can find.
We're lucky we have one young doctor, still a fellowship, that at least knew enough to say, I don't know, let me start researching and talking. They did talk to a lot of these doctors. So what I'm hearing is that yes, they follow what was supposed to be done. Just you have to accept that sometimes patients aren't, they're not responsive. They're not responsive to these things. Just didn't know. You know, hey, tried everything. You accept what it is. Hopefully the next one. If they could just diagnose it faster, there's a chance.
Yeah, exactly. Really. And if people would know about it.
Yeah.
Nobody knows about it.
I never even heard of it.
So violent.
I never even heard of this as B&B Center. I've never heard of Cincinnati's B&B Center. I've heard that there's there's doctors to know, but you don't know they're really clustering.
Yeah, I mean,
where do you go?
CCH and then some other center in Sweden.
Where do you go?
Yeah, we found this place and we're like, okay, we're moving.
Yeah.
Here from New York.
Yeah. You're here for the long haul.
Yeah.
You'll do it.
1, 2 years, whatever it takes.
Yeah.
I'm sure.
I was prepared to say, well, we had one patient, 4 months? Okay. I'm in it for the long haul. I got 6 months. Yeah. It's okay. You're in the process of a success story.
Hope so.
Yeah, the right place.
At least we're in the right place.
You're with the right people.
I'm sorry to hear it.
It's okay. Hey, good luck with yours.
So I'm Mike Jordan, and I'm a physician scientist here at Cincinnati Children's. When I was a resident, one of my professors, who was somebody I respected very much, who was an oncologist, she told me there was a new patient that was admitted the night before to the hospital, and the child had HLH. It was apparent by, within a few days, right? And she told me that it would have been much better if the child was diagnosed with leukemia than HLH. And she was a leukemia expert. So I was very impressed. I thought this is really something remarkable, and something that really I should learn more about. And that was as a resident. So I was sort of clinically interested, and then I became interested in HLH as a scientist after the perfin gene mutations were first discovered in 1999. Most of our patients are children, but I've seen a few patients that are young adults, and that is, I think, sort of the most amazing thing, that some young adults will have the same sort of genetic problem that normally you would expect to see affect a person while they're still an infant, perhaps, or a preschooler. I don't know how many patients there are in the U.S. every year, but it's probably measured in hundreds. It might be measured in thousands, but I'm sure it shouldn't actually be measured in hundreds of thousands, right? So it's always going to be a rare disorder, even if no patients are ever missed. Cancer is not one disorder, it's a lot of different things, and this would be one sort, even if it is. They're really
But it
different
still
things.
gets the funding because it has the word cancer.
True, yeah.
So if HISTIO got linked to cancer,
Yeah.
then it could
So LCH
possibly-
might, HLH wouldn't, no. In terms of how these diseases develop, they really aren't related at all. In terms of what you see when you look at the microscope, that's why they are sort of in the same sort of family of disorders, but they really do develop as two completely different disorders.
To us, it's devastating, but to a lot of doctors, it's kind of fascinating.
That's true. Actually, I was thinking about how best to put that, because it is that, exactly that, yeah. So speaking about HLH, right, it is an amazing sort of window into how the body works. It's a completely ironic, unexpected sort of outcome, right? The genetic defect that was discovered, you wouldn't guess, you wouldn't dream that it causes the problems that it causes, because the connections are not obvious. And so I think that HLH is telling us and will tell us a lot about how the immune system is normally regulated. And these are important things for understanding how our bodies work. Genetic diseases have been called experiments of nature, but it can teach us a lot of things, and HLH is absolutely in that category. I think it can teach us a tremendous amount. We have treatment regimens, right, that will quiet the disease in many patients, and transplantation is a cure if that's what's needed, right, for somebody. But there is a lot of things to improve. And there are new ideas being tested all the time, and new ideas, to be tested for sure. There could be, this would probably be a long ways off, there could be drugs that might help to sort of restore the balance in the immune system. There could be things like gene therapy that are not quite transplant, but they're still very involved, right? And still, of course, very experimental at the moment, but that could be a cure. That wouldn't have the same risks of transplantation. I think as a physician, it's something that I'm glad to take care of these patients, in part because it's a very challenging situation. I feel like it can really help people, and there's a lot of need. I mean, the families are, as you said, right? They're very, very seriously affected by this disorder. People don't understand it. It's sometimes very difficult to explain, and since it's not common, it doesn't have a lot of PR. So I think more exposure is a good thing in terms of helping families and helping research.
So tell me your name.
Susie.
How old are you?
I'm 6.
And what is the illness that you have?
Hemophagocytic lymphohistiocytosis.
That took me about like 3 weeks to be able to say that.
I was 2 when I had it. My mom told me that I was 2.
Did you have a bone marrow transplant?
My brother.
Your brother donated his bone marrow for you. If you could say anything to people, what would you want people to know?
What kind do you want?
The whole story.
The whole story of HLH and what it does to people.
Yes.
It all started with a fever, and I noticed she had jaundice. They thought she had hepatitis A initially, but I knew it was wrong because she had been vaccinated. The following day, those tests came back negative, and they sent her to the hospital for a liver ultrasound. And when they did the ultrasound, they found that she had fluid in her abdomen and her right lung, and she was basically suffocating. 2 days later, we were on a medevac flight from Hawaii to Cincinnati Children's Hospital. Quite frankly, we thought we were coming for a liver transplant. We did not think that we were coming because of her immune system being broken. About 4 days after that, we got our official diagnosis of HLH. Really just an immune dysregulation issue, and it's kind of like the overactive immune system, and this is how we're going to treat it, and this is where we're going to go. And then we met Dr. Filipovich. She was in the room with Susie, and she goes, "I need to speak with you." And at that point, I was so raw emotionally, I just started crying. Every time the doctor came in, I would start crying. She sat me down and she goes, "Gabriel's a perfect match." Gabriel, my son. One kid, what's the chances that it's the 1 in 25%, They were able to identify her gene. It was the syntaxin 2 binding protein deficiency. A lot of people have questioned our decision to use our son as a donor because he was only 5 years old at the time. Suzanne is actually a multiracial child. Her father is black, white, and Native American, and obviously I'm white. And, it would have been very difficult to find a donor for her. We just explained it to him like he had an opportunity to be a superhero. Choosing that route was definitely the best thing because it not only gave her another chance at life, her chance at life came from her brother.
Our daughter Brooke is an HLH patient, and she was just presented normal kid fever. She was 18 months old at the time. Went through about a full month of trying to get diagnosed as to what was wrong with her. Dr. McLean got a look at one of her blood slides and diagnosed her as an HLH patient, and she went under his care. She went through a bone marrow transplant here at the Texas Children's, at 22 months at December. And so she's 7 years post-bone marrow. It'll be 8 years this December, which is great. And her donor was her older sister, Tatum. A couple of the kids that'll run and give Dr. McLean a hug. They still, Brooke doesn't remember how many times she got stuck. So.
My grandson is 9 months old. He went through all the chemo before the bone marrow transplant. He had a bone marrow transplant on June 1st. There was no engraftment, so we had another one on July 3rd. He's been out of the hospital for about a week and a half. We have 25% donor engraftment right now. We're hoping for 100% very soon. And his parents, they're both home with him, my son and his mom.
One of the things I'm trying to do is introduce a new agent into conditioning for HLH condition. Transplants of conditioning is what you do before you do transplant someone. You have to give them very strong chemotherapy to remove the bone marrow. And one of the ideas is that kids with HLH have so much inflammation. Can we use some more specific immune suppressive drugs that maybe don't make them susceptible to infection or to rejection? Because rejection is a huge problem with HLH.
What causes HLH is pretty well known in most cases. It's a problem of cytotoxic T cell function. So your body gets a germ and you can't get rid of it. Your tanks don't have ammunition, so you keep calling the cavalry, but you can't get rid of what's causing the problem, and so that leads to this inflammation.
So cytokines are growth factors for white blood cells, and they are the hormones, if you will, or the factors that instruct our white blood cells to grow, and they are also the things that instruct our white blood cells to go someplace. They activate the immune system and they tell the immune system, get going. You got to do something, and they don't tell them exactly where, but they tell them, go find the trouble. They spew out these growth factors like poison gas, and they just put all these poisons out into the system, and that's what's damaging the organs too. So that's why it's such a bad disease. It's chaos.
We can tell from the immunologic testing that there is a problem related to the function of the killer cells. Killer cells are a population within the immune system. They are lymphocytes, and they are cells which can remove other cells within the immune system that are old, malignant, too turned on, need to be turned off. So they scavenge for various spent cells, and in that way they can cool down this abnormal immune response that we see in HLH. They are normal cells. They come in several flavors. Some of them are called natural killer cells because they know how to kill right out of the box. They're pre-armed to do that. And then there are killer cells that are T cells that have to be educated.
The histiocyte is a white blood cell, but there are several types of white blood cells, and it depends where they are in the body and what they're doing. So all these cells are normal, and it's only when the histiocytes or macrophages get activated in the bone marrow and start acting like Pac-Man and chewing up all their neighbors that there's problems. The macrophages or monocytes are a normal part of our blood. They're usually about 5 to 7%. And they typically aren't really high in the blood when a patient is even diagnosed, but they've collected, they've expanded, and the lymphocytes are partners in this problem, and so they're the two bad guys here are the lymphocytes and the macrophages or histiocytes. Their activation damages the bone marrow. The platelet count goes down, and the hemoglobin, the red cell count goes down typically. Unfortunately, for some children, even the medicines don't stop the gang fight, and these cells go on and cause fatal damage to the kidneys and liver and lungs and brain, and could even affect the heart. So at its very worst, it can affect every single organ in the body. Any infectious agent has been associated with HLH or MAS. I mean, it's just whatever excites the immune system. From August through October, we'll expect a peak, and then we seem to have a bunch of them December through March. And I've never done an epidemiologic study or found viruses associated with it or understood why that is.
What are your thoughts on MAS and HLH being the same biologically?
I think they're kissing cousins. They're very similar mechanistically, and also we are finding that some of the mutations, some of the genes that are mutated in the classical HLH are also mutated in MAS. It's just that no one really looked before. So we're having more of an alignment with the rheumatology community that takes care of these types of patients and that studies them.
MAS and HLH are both very dangerous diseases. If you want to cut it with a very fine knife and say that MAS is more associated with systemic juvenile rheumatoid arthritis and lupus, and HLH is more associated with little babies who have a gene defect, you can say there's some difference by the type of people affected. But the biology of the disease is the same. There are 8 criteria that we use to diagnose it that were set up by the Histiocyte Society several years ago. And you need 5 of those criteria to be fulfilled to make the diagnosis. The problem with the diagnosis of this disease is it's been wrapped up in these 8 diagnostic criteria. And people get so caught up and so focused on lines 1 through 8 that they don't either know about or think about or factor in all these other things that could be really important. So if I see a patient with high fevers, a large spleen, 2 blood counts down, and a ferritin of, say, 50,000, but they don't have anything else that's on that list, and they're in the ICU on a respirator and have renal failure, I'm going to be pretty darn suspicious that they have HLH, and then I'm going to start doing I'm going to send all the other tests, but then I'm going to start them on therapy. And that's where the problem comes, because if you don't start them on therapy as early as possible, you might lose a chance to cure them. And the cure right now is based upon primarily dexamethasone and etoposide. Etoposide is considered the frontline therapy, so that's the first thing that you would use along with the steroids, dexamethasone. I think that if the patient has not improved by the second week of treatment, that you need to add something else. There's a new medicine that's been used, it's called Campath, which is not a chemotherapy drug. It will attach to certain characteristics on the histiocytes and the lymphocytes. And if you can attach something to those surface characteristics and then eliminate those cells, like a magnet pulls iron filings out of a pile of sand, then you get rid of the bad cells in this disease. When you use this Campath, you really take away the immune system. And if you do that, the patient's very vulnerable for dangerous virus infections. So we really prefer using this only when we're ready to do a bone marrow transplant.
If there's a genetic problem, right, and you replace the stem cells, and that'll replace the bone marrow with cells that don't have that genetic problem. For decades now, we've already been doing stem cell research, right, and therapies, and that's called bone marrow transplantation.
If the patient has an Epstein-Barr virus infection, there's a medicine called rituximab, which is another antibody, but this one attaches on to the B lymphocytes. And the B lymphocytes are where the Epstein-Barr virus likes to live. It gets in there, and it's just like a little cocoon. The virus reproduces in there, escapes, and then can cause lots of problems in the body. There's a new protocol that we talked about we're going to start, and it's to use a medicine called anti-thymocyte globulin. So this anti-thymocyte globulin takes away T cells. It takes away a lot of these inflammatory cells very quickly and gets the patient under better control quickly, and then they used the other medicines, and it kind of kept them under control, but all these patients were going to bone marrow transplant. So unfortunately, some of these patients started to relapse just before transplant. So we think that if we use the anti-thymocyte globulin and the dexamethasone and etoposide more together, that we can have a better outcome. Our paper, How We Treat HLH, will be published in the Journal of Blood very soon, and that is a very high-impact journal, and this paper will tell the world all these nuances of treating HLH patients, things that we've learned by treating many patients here that were not widely known in the literature. We recently found that using measurement of serum ferritin is a sensitive marker for HLH. By following the serum ferritin, we could kind of predict whether a patient was going to be doing well or not. We found that using cyclosporin in these patients could be quite problematic, and we were able to measure and evaluate the patients who are having central nervous system toxicity, and led us to modify the way we use this drug and hopefully increase the safety and efficacy of treatment of HLH patients.
We've learned that a certain product that's made by the immune system called gamma interferon is probably critical to sustaining the HLH-MAS activity. So if you could neutralize that, which you can in a mouse, you can reverse the disease. And that's very targeted therapy. It only goes after, that particular molecule that's doing the dirty work and doesn't have all this collateral damage. So that's an example of the sort of thing that I think needs to be developed to be able to treat patients even when they're in organ failure.